It gives a wide exposure of hip joint and double layer capsulorrhea. The stability of the hip joint after open reduction depends mainly on adequate removal of soft tissue obstacles. We can see this as a soft tissue obstacle like the limbus and the ligamentum teres, tendon of iliopsoas and bulvinar and capsule ligamentum teres. And the proper correction of the bony configuration. We can go for proper correction by either pelvic osteotomy or femoral osteotomy or by both. The soft tissue obstacles in the case of DDH, the acetabulum is filled with inverted limbus. This is the shape of the normal acetabular labrum. In case of DDH, there is hypertrophy of the acetabular labrum and become enlarged in the superior and posterior and inferior rim. It may fold into the joint and become inverted limbus, as seen in this photo, this inverted limbus, and in this cadaveric section. This limbus blocks the reduction of the femoral head. The second obstacle is the bulvinar. It is a bifibrofatty debris presented inside the cavity of the acetabulum, like this photo. Also, the interposed iliopsoas tendon, as we see in this photo, and the ligamentum teres, the capsular constriction, which caused by the iliopsoas tendon, and finally the transverse acetabular ligament. How to deal with these soft tissue obstacles? The bulvinar are removed, the ligamentar teres are excised, the capsule is opened, the labrum either left intact or if it is severe huge, we can do a radial incision on it, and the iliopsoas is divided, and the transverse acetabular ligament are divided. To deal with these soft tissue obstacles, we need a very good exposure of the hip joint. So we need a very wide exposure in the capsule, but we cannot excise all the capsule. This exposure depends mainly upon the used method for opening the capsule. The types of the capsular incision, number one is T-shaped capsular incision. As we see in this photo, it is a T-shaped capsular incision after opening the superior and inferior flap of the capsular incision in the capsule. Then inferior advancement is the upper flap, and the inferior flap is the excess capsule in the inferior flap are excised, as shown in this photo. T-shaped capsular incision with Salter type capsulorrhaphy is normal or ordinary T-shaped incision in the capsule. Then these shaded area are excised, and we do a medial rotation of this flap from the capsule, so the side of the T limb of the T incision are inserted in the anterior inferior iliac spine, and the side of this B type are inserted in the periosteum of the pubis. This is a final diagram for this Salter type capsulorrhaphy. Then T capsulotomy with vest over pants capsulorrhaphy. This T-shaped incision after opening the two flap of the T-shape. This pants over vest technique for repair of the capsule, and this repair of the capsule after reduction of the hip joint. Number two, mini bikini shaped capsular incision. It is a longitudinal incision in the capsule like a bikini incision, and after reduction of the hip joint, we try to put each letter with adjoining each corresponding letter to do a capsulorrhaphy. This is the same technique as a mini bikini capsular incision with the excision of part from the capsule. This part of the capsule is excised and do medial or inferior rotation of the inferior flap to close the capsule. The U-shaped capsular incision, this is a new technique done by our colleague Dr. Hisham El-Basit from Asyut University, and it is a very good technique. It is a U-shaped incision in the capsule, and we after reflect this part, we can see the head of the femur and part of the acetabulum, and after reduction, we can close this flap again. And finally, my own technique is S-shaped capsular incision and double layer capsulorrhaphy. Simply, it is the shape of this new technique of the capsulotomy. It's like a letter S. This is a S-shaped incision. After opening the S-shaped incision, it is a rectangular flap and it is triangular flap. It gives a very good exposure for the acetabulum. The upper edge of the obturator edge can be seen. The ligamentum teres and transverse ligament become visible, and we can do easy radial incision for the inverted limbus. This is the diagram for our own technique. It is S-shaped incision. It is the side for quadrangular flap and the side for triangular flap. After opening both flaps, the quadrangular flap and the triangular flap, we can see obviously the hip joint and the acetabulum is clearly visible. And this is the site of the original S-shaped incision. It's S-shaped incision again. And this is a photo of operative, intraoperative photo for my own technique. It's simply the anterior exposure of the hip joint, Smith-Peterson exposure. And we can see the acetabulum. And this is the site of the acetabulum, the site of the head of the femur. And it is a site for capsular attachment. And this is outline of the bony landmark of the hip joint and site of the capsular attachment. We can do first the quadrangular flap at this site. After magnification of this photo, we can do the quadrangular flap, and after opening the quadrangular flap in the site of the Sermi marks in the capsule for the quadrangular flap, and this is after opening the flap. And we can show the video after opening this flap, and the head of the femur is obviously seen. Then we retract the iliopsoas and sartorius muscle to expose this side of the capsule. This is a site of doing the second incision or second capsular incision at this site. It's done by diathermy. And after opening of the second flap, the triangular flap. And this photo after opening both the quadrangular flap and the triangular flap, we can see the acetabulum clearly visible, and the ligamentum teres and the pulvinar and the inverted limbs. And shows a video for opening for both flaps. Then we talk about the double layer capsulorrhaphy. It's a photo diagram for the dislocated hip and after reduction. It's a site for S-shaped incision in the capsule. And after opening the both quadrangular and the rectangular flap, we can notice that both flaps are not in the same plane. But after reduction, we find both flaps at the same plane. Then we close the triangular flap at first, and then close the rectangular flap. Then we can choose the photo, intraoperative photo after closing the rectangular triangular flap, and then this is the site of the quadrangular flap. And this is the photo after closure of the quadrangular flap. If we compare between the most common methods of capsulotomy, either T-shaped or U-shaped or S-shaped, after opening of the capsule, we can see that S-shaped capsulotomy can give a wide exposure for the hip joint. And it is interoperative photo for the original articles for the T-shaped capsulotomy or U-shaped capsulotomy, and it is my paper which is under press. We can see that this exposure is a very good exposure for the hip joint to can get rid of all soft tissue obstacles in the hip joint. We notice that there is a change in the flap direction after reduction of the femoral head inside the acetabulum. So this direction of the flap before reduction is vertical in the craniocaudal direction, but after reduction we found that the flap or quadrangular flap become in the mediolateral direction. Why? At the beginning, this site of the quadrangular flap, and this is the base of the flap, is the red line, and it is interoperative photo, and it is the base of the flap. After opening of this quadrangular flap, then we can choose the direction of the flap with gradual reduction of the hip joint. And finally, after reduction. At the beginning, the base is horizontal, then become vertical after reduction of the femoral head. After reduction, this is the quadrangular flap. And after suturing this quadrangular flap, we can choose the direction become horizontal, which was previously vertical in the first one. So as the first, the quadrangular flap is vertical in direction and finally become horizontal in direction. Thank you.
Thank you so much, Professor Mohammed Lakluk, for presenting this unique technique of management of DDH. Thank you so much, sir. We have just only one question. I think you have mentioned it and you have answered it, sir, from Dr. Abdullah. What benefits, what shape of capsulotomy provided? Why would I prefer S over U or T shape? I think you have answered
I discussed it in my lecture. It gives a wide exposure, so you can get rid of from any soft tissue obstacle.
Yes, sir. Thank you so much, sir. I think we have no more questions. Thank you so much, Professor Lakluk, for joining us. Thank you so much, sir.
Thank you, Dr. Rajab.
Our next speaker will be Professor Ibrahim Abu Umaira, Professor of Orthopedic Surgery and Head of Al Azhar Asyut Orthopedic Department. Professor Abu Umaira will speak about management of paralytic hip dislocation in children. Professor Ibrahim. Professor Ibrahim, you are with us, sir? You are muted, sir. You are muted, Professor Ibrahim. Professor Ibrahim, you are muted, sir.
Hi. It's okay?
Yes, sir.
Good evening. Assalamu alaikum. Many thanks, Professor Muhammad, for nice work and great effort. And it is my honor to speak new subject about new blade in proximal femoral osteotomy. Hand in hand, improve our skills. This is our aim. Sorry, I don't. This is not working.
It was working before, sir.
Working before. Sorry.
You can stop sharing and make another time sharing, sir.
Okay, that's right.
Yes.
It is a new blade for proximal femoral osteotomy. It's called interlocked cannulated blade. And our aim, hand in hand, improve our skills. Spastic hip disease is acquired hip dysplasia caused by muscle imbalance. It is still orthopedic challenge as they are difficult to treat and cure. It is not congenital. Hip problems specific to CB. Subluxation, very common, non-ambulatory patient. Hip subluxation will develop in 50% of quadriplegic CB patient. Why do surgery in CB patient? Because about 75% of hip dislocated will become painful. Etiology of dislocation is either soft tissue or bony problem. Soft tissue contraction of adductors and the iliopsoas. Bony problem, coxa valga, excessive femoral anteversion, and the acetabular dysplasia. Our goals: fix everything at one time. New deformity less, recurrent deformity less, offer lengthening less, one hospital admission. Please don't create birthday syndrome by offer lengthening or recurrent deformity. We use a lot of implant in proximal femoral osteotomy, like pediatric DCS, pediatric DHS, PD-LOC, and the femoral plate, and the LCB plate, but blade became the most widely used implant because their sound biomechanical basis, supported by several large retrospective studies showing excellent results. Proximal femoral osteotomy is the major and the common osteotomy in pediatric child. Complication of conventional plate is, as you know, children in CB is the bone fragility, wrong direction, or movement blade in the neck of the femur. So secondary displacement is common. Secondary complication, delayed union or non-union fraction under blade. As you say in this case, this is a fraction under blade because we use a blade with the screw 4.5 will be a stress fracture under blade. Late complication, look this case, this is a avascular necrosis of the head because the blade is coming posterior in the neck, and there is overcorrection will lead to avascular necrosis of the head from wrong directions of the blade. To avoid this complication, such wrong direction, move mid blade in the neck of the femur, pulled out of blade, and increase prominence of blade under skin and soft tissue irritation. Look for cases double angle blade, there is skin irritation and ulceration over the blade. Because as you know, CB child has malnutrition and malnutrition, low weight. So this is the over prominent of the blade under skin will lead to ulceration and necrosis. After review of literature, we observed many trials to increase stability of the blade by screw from inserted from proximal to distal to increase stability, and we invention a new technique, screw from distal to proximal to increase stability of the blade and prevent pulled out blade in our new blade. Also, after review literature, we observe it cannulated blade. This system not available in our country because it's very expensive. So most of our patients can afford. This is the new system. This system. So on previous complication and difficulties, we decided to introduce implant in controlled fashion. We assumed that is a new system would offer significant advantage over existing system, include more stable fixation, more easy, more safe learning care for trainees. It's available three possibilities: stable, easy, and safe for new trainees. So a new modification plate called decrease profile plate from 4.5 to 3.5. This is a conventional plate. This is our new plate. Decrease from 4.5 to 3.5. Cannulated blade, this is a cannulated blade, is a cannulated blade to allow easy insertion. This is a blade, the same size of a blade of a sitting chisel. Also, sitting chisel is a cannulated. Decrease angle plate from decrease second angle. This is the angle decrease from 42.5 to 90 degree. Why? To decrease prominent plate under skin, don't affect mechanical axis. We use interfragmentary locked screw. It is passed from distal to proximal to prevent bolt out of the plate in oblique direction 30 degree. The workshop of a plate, how insert the plate and do varus proximal osteotomy. Modification of cell steel to titanium to decrease rate of infection. To prevent confusion, we summarize in this table. This is a conventional plate and this is a new plate. A new plate, this is a hole for screw from distal to block.
مش عارف بيت هيسولا
This is the screw from the proximal distal to proximal to prevent bolt out of the plate. This is the table summarize the difference between old conventional plate and the new plate. Profile 4.5, the profile 3.5. Interfragmentary screw is absent and present in our plate. Cannulated plate is absent and present in our plate. First angle 90 degrees the same, and the second angle decrease from 42 to 20. Material stainless steels and titanium. Screw 4.5, 3.5. Length of blade about from 35 to 50, the same, and the length of the shaft is the same or more or less more in our thickness of blade is the same or less in our new blade. So we use different blade. This is a blade from 35, 45, and 50 according to the length of the neck. And also we use modification for new blade about 120. This is a blade used for neglected ditch. This is a video. This is a video showing how to design a new blade. This is a blade, and this is a bridge to prevent side-to-side movement. And this is a oval screw for interfragmentary screw. This is the second angle, and this is the first angle. This is the length from 35 to 50. This is a bridge, and there is thickness here to prevent breakdown of the implant failure. So the thickness is gradually decreased from distal to proximal. This shaft about 8 centimeter. The second angle. Instrument in our new blade sitting chisel, very important one. This is sitting chisel, very important one. This is the key of our work. Sitting chisel is cannulated at same size of the blade. A blade holder to catch the blade, drill bite 2.5, screwdriver, guide wire 1.5, sleeve. So surgical technique is a new technique from our use wire in central in EB and AB and the lateral intensifier image. This is the wire in EB, and this is another wire below laser trochanter, and this is the wire above laser trochanter to create a triangle from base medially. We need to do closed wedge to need more varus of the head because most of CB in valgus, as I said before. This is an intra-operative photo showing 3 wires inserted, one in the neck and one below laser trochanter, above laser trochanter. This is the sitting chisel bus according to inserted according to guide wire, and the pass easy to the neck. This is the intraoperative X-ray to showing how to insert it sitting chisel in the neck. This is the osteotomy to above key wire and the below key wire to create medial triangle. This is the triangle created medially. We use now inserted the plate. The plate, our assistant to do flexion of the hip and the abduction of the hip to allow easy inserted plate with the guide wire. This is an intraoperative X-ray showing how to insert a plate with the guide wire. And this plate automatically created varus of the neck. This is the intraoperative X-ray show how to insert the interfragment screw. Not need image, just a pass by sleeve to pass from distal to proximal drill bite to insert it in the hole of the neck. And this is the wire. This is the interfragmentary screw. This function support the blade and also to prevent bolt out, as I said.
Third time, please.
Say again.
Sir Ibrahim.
Yeah.
Time, please, sir.
Type. Okay. So now this is the intraoperative photo in epilateral. We use in most of our cases Degas osteotomy. Degas osteotomy as harvested bone from the proximal femoral osteotomy and from neck of the and iliac bone. This is the bone bridge from the acetabulum about 10 millimeter. The key wire pointed to medial tricartilage. This is the Degas osteotomy. This plate was registered in real estate registry and the Egyptian Ministry of Scientific Research. It's published in orthopedic trauma surgery last year and also presented in Sekut in Malaysia 2022. The first case will present some cases. The first case, male child 4 years old, presented by right paralytic hip dislocation. We use triple attack in our procedure. This is an intraoperative photo how to insert the plate and the varus osteotomy. I have to quickly. This is a follow-up after 1 month. Use cast for 1 month, and this is follow-up after 3 months. Completely united proximal femur. This is after removal of the plate. Another case of the same child, 4 years old, bilateral paralytic hip dislocation with the same maneuver, triple attack. In our cases, we use open the capsule because this is a long-standing dislocation. Ligamentum tear is very long and hypertrophied when do varus and not concentric reduction. So the best remove ligamentum teres and capsulorrhaphy. This is the same cases. This is after 3 months completely united. Another case with the blade. This is some cases there is created lateral close open wedge. We use the graft to close this wedge and they're completely united after 3 months, as say these cases. This is the last case. We use 120 new blade for this case. This is a neglected DDH. We use this blade with varus and triple attack is the same. They're completely united after 3 months. Take home message. Spastic hip disease, acquired hip dysplasia caused by muscle imbalance, still orthopedic challenge as they are difficult to treat and cure. Necessity is the mother of invention. We assume the new blade would offer significant advantage over existing blade, including more stable fixation, more easy and safe learning care for trainees. Thank you for your attention.
Thank you so much, Dr. Ibrahim, for this very interesting technique and very interesting plate. Thank you so much, my dear professor.
Thank you, Basir.
Thank you, sir. Before we move to, I think we have no more questions. Before we move to the last speaker in the pediatric session, I remember all of you with the very important workshop transmitted lively from Canada in the next Friday in the international section. It will be from Canada, McMaster University, Professor Walid Kashta, live workshop on osteotomies around the hip. It will last for 1 hour, and it will be at the end of the second Friday, 26th of January, 2024, and it will be live transmission from Canada. Our last speaker will be Professor Sharkawi Waghi from Aswan University. Dr. Sharkawi will speak about CP hip problems. And after we finish the pediatric session, we come to the hip arthroscopy session. Dr. Sharkawi, please. Dr. Ibrahim, please, would you please stop your attention, please, sir?
Okay, thank you.
Your presentation, I'm sorry, your presentation, sir.
Okay, stop sharing.
Thank you so much, sir.
Okay, welcome.
Dr. Sharkawi, please present your presentation.
Okay. Is it okay now?
Yes, sir.
Assalamu alaikum.
Alaikum assalam wa barakatuh.
Thank you, Professor Mohammed Al-Ashhad, for inviting me to this brief session. I'm happy to have you all. I think most of my professors and colleagues cover this point more than enough. I hope to add something. Why this topic is important? Magnitude is a problem. We will talk about magnitude as a problem. We will talk about the pathology and the etiology of CP hip problems. We'll have an idea about the natural history. We have to emphasize the role of hip surveillance in our community and how to catch those patients in between the crowdings with our outpatient clinic. And some treatment recommendation. I will not gonna do some techniques or tips. Magnitude is a problem. CP hip problems are the second most common after ankle equinus. 90%, every 10 patients, we have 9 of non-ambulatory CP patients have hip dysplasia and hip displacement. 1/3 of all CP kids have some hip problems at any age. The most to affect the quality of life is the hip, unlike the ankle and the knee. Most common base of CP literature, 1,360 publications, and now we don't have standard protocol regarding the time and dose of surgery. Non-ambulation is the core of the problem that guides the natural history in those people. These people and those kids are medically fragile. So surgical treatment is demanding and with the high mortality rate. Unlike the ankle and the knee, orthosis and bracing doesn't work. Why to treat those people? The aim is to obtain and maintain. Maintain is more important than to obtain. Painless, mobile, free hip with symmetric range of motion to facilitate daily life, like transfers and seating and nursing. In walkers, it's very rare for walking people and walking CP kids to have hip problems, but very few exceptions like type 4 hemiplegia and late dysplasia in some diplegics, and gait problems due to scissoring and soft tissue imbalance. Non-walkers is our issue. Non-walkers is the focus of my talk. They have difficult sitting and wheelchair use. They have difficult care and hygiene. They have constant pain. They do dislocation and arthritis. They have scoliosis. Common scoring, we have many scores to evaluate those people, but the most common is gross motor function classification. Everybody knows that. We have Melbourne CP hip classification system is the radiological classification mainly. We have CP child and pediatric quality of life inventory. The last two are parent or caregiver priority. This is gross motor function. We have to focus on type 4 and type 5. Type 5 people don't have trunk or head support. Type 4 they have, but they can difficult to walk or just standing. This is Melbourne CP hip. It's mainly radiological, taking into consideration pelvic obliquity. CB child is caregiver priority and child health index, as we see, is like questionnaire to evaluate the satisfaction of the parents and caregivers. The same is for pediatric quality of life inventory. This graph showing how type 4 and type 5 are the most common category that have hip problems. Diabetic patients, sometimes they have after adolescence. Hemiplegic type 4, they have also hip problems. We have to focus and understand the pathology of CB hip dysplasia. They born with normal hips. The abnormal forces of muscle spasticity gradually subluxate and pull the head outside the hip. This force is very hard, more than the force of standing. So they have very high joint reaction force. They have multifactorial bony and soft tissue problem. So just lengthening tendons and doing adductor tenotomy is not enough in those people. For soft tissue, we have about 59 articles discussing soft tissue pathology. They have abnormal force, magnitude, and muscle spasm. They pulling the head in the wrong direction, posterior, lateral, and superior. The adductor longus and gracilis as the main deforming force, sometimes iliopsoas, hamstring, and pelvis work. Those category of patients have weak abductors. This causes imbalance. That's why soft tissue not working without redirecting the hip inside the hip again. For bony etiology, we have also a very big data of research that discussing the bony etiology in CB by name. Prolonged non-weight bearing is the main and the key behind the pathology of the changes, the bony changes in this category. Proximal femur and acetabulum have both deforming forces. Proximal femur increased neck valgus and excessive anteversion. This influences hip dislocation more than its spasticity itself. And as we see, gross motor function classification 5 are the worst to have this neck shaft angle. The CB hip dysplasia is different than DDH. They have posterior and lateral coverage. Okay, so they have decreased medial pressure, and if you do X-ray for these people, you find the teardrop very wide. The pathology, etiology, and displacement of hip displacement in CB is multifactorial. The most common risk factors: gross motor function classification and young age. Typical age of presentation from 2 to 8 years. CB hip is positioned most of the time in flexion, abduction, and internal rotation. Typical posterior superior direction in 99% of the patient. Without treatment, the hip completely dislocates, and the acetabulum open up and coming into dysplasia. This is a proximal femoral deformity. They have coxa valga, very high neck shaft angle. They have increased femoral anteversion. The only way to improve this is to walk and to stand, and they never walk and never stand. So this pathology continue even after hip reconstruction. This is the most common cause of failure after hip reconstruction. The pathology is still working. This graph showing why those people getting progressive coxa valga. The epiphysis and the fibrils of the proximal femur are working in perpendicular to the joint reaction force. So it grows longitudinally. The neck increase in length, not in width. This is a very simple table comparing DDH and CB hip dysplasia. DDH born with dysplasia with temple pathology. CB hip was normal hips, but they start to sublux gradually. Diagnosis, we just need a screening test, but in the CB hip, we have to keep an eye up to maturity. We need surveillance, not screening. The DDH, just non-operative treatment to just tenotomy and abduction braces work, but in CB doesn't work. General condition, DDH is a normal child, but CB is a fragile patient. As we see before, they born with normal hip. The highest risk is between 2 and 8 years. We will show now the natural history of the CB hip without any treatment. They born with migration percent, normal, 10%, 2.5 years, 5 years, 8 years, 10 years, 13 years, and 15 years. They have complete dislocation. This is natural history of CB hip dysplasia. The natural history in adolescents, usually adolescent people, walking people, if they have migration percent lower than 30, they never have hip problems. But in hemiplegia, sometimes they have after maturity. They have very high risk of hip displacement after maturity. The natural history in adult, if the adult was adolescent with migration percent of 30%, they usually don't have hip dysplasia at maturity. To diagnose, we have to clinically do abduction, simple abduction. If we have limited abduction, less than 30 degrees, we have to do X-ray, then X-ray, supine X-ray with neutral rotation and abduction. We have better to put a pillow below the trunk, below the side, because if you take AB view and the CB chart, actually you will take end view because the hip is always connected. Riemann migration index is the simple way to measure how far this head is outside the hip. We have to measure the lateral extrusion part, which is presented by A. The whole width of the head femur, A divided by B, this is percentage of migration. Sometimes we need 3D CT. Some centers adopted every patient we have to do CT before surgery. Also, it's very nice to allocate the other hip that looks nicely on X-ray, but if you do CT, you will find it's dislocated. Very nice to determine how femoral anteversion is, and in revision cases, and in the contralateral hip that looks nice on X-ray. This is
Professor of Orthopedic Surgery, the National Institute of Locomotor Surgery, Locomotor System, I'm sorry. Professor Amr will speak about the updated surgical technique of SAFE.
What happened already, but you have to be shortened your lag screw to avoid migration of the screw within the acetabulum.
Yes, thank you so much, Professor Said, for this.
Should I continue in my presentation or not?
What happened, sir?
Professor Ashab, I heard some people talking.
Yes,
maybe
please,
Professor
please
Said Abdel Hamid.
Go with your presentation.
Okay. This is simple.
Go with your
this is 3D CT that show how far the anteversion is very high in this category. The video is working. The video is okay?
Yes, sir.
The contralateral nice side is not nice. It's very high anteversion and have dysplasia. So my talk, maybe I can be happy to talk about hip surveillance. Every child with CB is a candidate for hip surveillance, but not every child of CB is not candidate for hip surgery. To do hip surveillance, we have to do simple EB, X-ray with some below the side. And it depends on the gross motor function classification. In non-walker, we have to do it until the age of 8 years. We have to do it every 6 months until the age of 8 years. Surveillance sometimes make anxiety for the doctors, for the parents to monitor the dysplasia, but it's very beneficial in education and parent caregiver education, and also to clinch dislocated kids very early. Surveillance is very important from the journey, from birth, not from birth, from 2 years old up to maturity, and after adolescence sometimes we have to clinch the patient in his journey to treat as needed. Treatment CB, we can roughly divide it in prophylactic measures, reconstruction, and salvage or replacement. Prophylactic is the best to attempt to avoid high dislocation and early reconstruction. Surveillance is the best way to make time intervention. Botox and adductor brace is ineffective. Please don't do Botox and adductor brace because every literature is denying this. Specialized abduction brace for wearing more than 12 hours is not working also, but sometimes it held after therapy. So, surgical obstacles of those category: non-walker CB, cognitive communication facility problem, low bone quality because of malnutrition, no sun exposure, not walking. They have also pulmonary and feeding problems. APR is abductor psoas release of CB. Is it 80% success or 80% failure? Abductor psoas release surgery worked least for those children who need it most. Unfortunately, Benjamin Shorey of the Boston Children's Hospital says that this maneuver is very nice, but not in non-walkers. Abductor surgery seems to work better.
Time, please, sir. Time, please, sir.
Oh, okay. I'm sorry. Gross guidance is a new topic and a very good topic for research. Non-ambulant children will never resolve infantile coxa valga and increase femoral anteversion. So we have to make a dynamic method to correct this hip. We have to put kinetic screws in the infromedial cortex, and we have to repeat it because the screw is pulled out with gross. Hip reconstruction is the gold standard method for prevention of hip displacement. This consists of bilateral adductor lengthening, bilateral varus derotation osteotomy, and proximal femur osteotomy. What to do for contralateral located hip if we have one side dislocated and the other side is located? Actually, the other side is not, if you do CT for the other side, we find it increase femoral anteversion and coxa valga. And if you correct the dislocated side, the other side will dislocate soon or after 2 years. So we have to correct it even by varus derotation osteotomy. This is my study in South Korea from 3 years ago, discussing the outcome of varus femoral derotation osteotomy for spastic hip without adding pelvic osteotomy. I'm gonna finish my literature about the salvage surgery. This is the view of the femoral head if you open it in high dislocation and chronic dislocation. So it's contraindicated to make reconstruction in those people because the pain will increase soon. For salvage surgery, we have 3 techniques: proximal femoral resection. We have valgus trochanteric osteotomy. We have both techniques. We have to understand the pathology of the head TB to avoid underestimating the problem or doing unnecessary surgery. Unlike ankle and knee, overdo and overestimation is better than skillful neglect. Say hi to non-ambulant CB child, then request an X-ray for him before saying goodbye. Hip surveillance is the most important in monitoring and timely appropriate intervention. Patience and teamwork for medical optimization is fundamental. Hip reconstruction is the most and gold standard method for reduction of those hips. Only soft tissue is not working in those people. With the best hand, salvage surgery has poor outcome and can be avoided. Thank you so much.
Thank you so much, my dear Dr. Sharkawi Wagih, for this very interesting talk about CP-HIP, and many thanks to all our dear speakers in the pediatric HIP session. Now we will have to move to the next session, which is HIP arthroscopy session. Our first speaker will be my dear Professor Hatem Jalal Saeed. Professor Hatem will speak about labral repair and pincer phi management. Professor Hatem.
Thank you very much, Professor Muhammad. Can you hear me well?
Yes, sir. I can hear you, sir.
Thank you very much for the invitation, and it's an honor to be with all our distinguished speakers in this webinar, this great effort. So my presentation. So my presentation is about labral repair, tips and tricks, and pincer management in femoroacetabular impingement. And my friend Ahmed Abdelazim will also speak about CAM management. That covers really the most important 2 parts of managing FAI surgery. So when we think of labral repair, this is just my disclosure. It's not related to this presentation. When we think of labral repair, there are 2 main points. Usually there's always an associated degree of pincer with the labrum, so we always have to manage that. And then the technique of actually repairing the labrum itself. So when you're repairing the labrum, there are several questions that we should prepare. Which portals we will use, the acetabular plasty or pincer management, the sutures that the anchors we will use, whether they are knotted or knotless. Do we do a loop or a labral base refixation? Do we separate the chondrolabral junction? And how do we penetrate it? And then do we attach a knot? And lastly, what do we do about the far away anchors, the one most medial and the one most posterior for posterolateral impingement? So for portals, this is the classic arthroscopy portals that we use. We use the proximal anterolateral portal and the distal anterolateral portal. These are our viewing and working portals for the peripheral compartment. We start with peripheral compartment first. Once that is done, we go into the anterolateral portal, which is for the central compartment. We do our repair, we do the first two anchors, and to do the most medial anchor, we do an accessory distal anterolateral portal, which is more medial. This gives us access to the most medial anchor. So it's very important that you do the acetabuloplasty. Most of the times with the cause of the labrum, it's not only the cam, but I would say in 90% of my hands, there is some degree of pincer that we must manage. So it's important that you actually work on the pincer. You decompress the labrum because the extra bone is coming from the acetabular side, pressurizing your labrum. So you're decompressing the labrum to allow the labrum to go back into place. This reduces the impingement with the femoral neck even after doing the cam osteoplasty. So it's important to realize and go to the chondrolabral junction, and you see that it's been softened and there is no bony protuberance behind the labrum, preventing it from receding backwards. So our work always starts with peripheral compartment. We do the cam, and then we also do a big portion of the acetabuloplasty or the pincer management in the peripheral compartment, inflection of about 70 degrees. That has a great advantage on reducing the traction time. The traction time is closely related to the amount of complications that happen. With this technique, we're able to minimize the traction time to about 45 minutes. That includes putting in 3 anchors in the operation. So the whole operation and the traction time is reduced if you utilize this technique. So this is an example of a pincer subspinous impingement, which is, as I said, abutting on the labrum. You can see in the upper image, the preoperative view, and you can see on the lower image that we've decompressed the subspinous area that's been compressing on the labrum, and this allows the labrum to recede backwards. So which anchors do we use? We're utilizing now all suture anchors. We moved from the metal anchors, which have artifact with the MRI, PEEK anchors, which are solid and they are big. And now we need to be as close as possible to the articular margin. So we need the smallest size anchors, and the safest one to use are the all suture anchors. Most of the companies have those at the moment. They start from 1.3 millimeters up to 1.9 if they're double loaded. This allows you to come very close to the rim, avoids labral eversion, because the further away is the suture, the labrum will cause eversion. But when you're close, you can actually keep the inversion, as I'll show you in the upcoming videos. And even if by any error, there is penetration of the articular surface of the acetabulum, they depend on the mechanism of retraction. So even if they penetrate, you just retract them back and they're not inside the joint. So, and also now with the new guides, you have a curved trajectory. So the trajectory is away from the acetabular edge. So it lessens the potential for complications. And as we said, the mechanism is you pulling to deploy in most of them, or even if the deployment mechanism gets them backwards, even if you penetrate, it does not cause a problem. Now, do we use knotted or knotless? Both are available. The knotted ones allow you to adjust the tension better, allowed you to really control the tension before you do your knot. It allows you to control very sensitively the inversion, eversion, and they are reversible. If you do too much, you can untie them and control your inversion, eversion. The knotless one has been classically the PEEK ones. They were larger, so we had to go away from the articular margin. Now we have the knotless old suture, which have the advantage of being smaller and closer to the margin. It does not involve any knot tying, so you don't need the skill of knot tying, and you have shorter stitches and less adhesions. So this is an example to show you the difference between the knotted and the knotless. So they're both, you can see, very close to the articular margin, and the one at the top is a knotless. There is no knot here, so potentially less adhesions with the capsule post-operative, and knotted at the bottom but since they are very small ones, I don't see much of a problem with that. This is an example of the knotless anchor, which is a peak one. And this is a big one. This is an older version we used to use. Apologies. This is an older version we used to use, and I don't use it anymore because of the size. This is more than 2 millimeters, about 2.7 millimeters. But again, as you see, I don't have control on eversion of the labrum. You have to really predict the tension. So as you go in with the labrum, as you go in with the anchor, the labrum everts backwards, which you don't want that. You want the inversion to maintain the labral C. But these are the more newer ones, which is the tension adjustable knotless anchors. These are the very new ones. And these are very nice. They're small in size. They're close to the margin. They are knotless, but you are able to, by the time you do your suture, you're able to do a more eversion or inversion even by the knotless. If you look at the picture down on the right, you can see that we're tensioning. It's compressing the labrum without causing the inversion and maintaining the labral C. So these are adjustable all suture or tension controlled knotless sutures. Now, this is the classic anchor that we use, is the knotted version. Again, we always do one loop around the labrum, and this again allows us to control the inversion. I'm stressing on that point because it's very important to maintain the labral seal at the end of the operation. So we do the tension while maintaining inversion of the labrum, and then we do our knot tying. So some people suggested that we do labral penetration. You do called labral base refixation, but the same authors later came out and said there's no difference in clinical outcome between if you go around the labrum or you go through the labrum. So I still go around the labrum. I'm able to reach a very good fixation and loop fixation around the labrum. And I think after a while, shortly with the tension, the labrum tissue itself will develop the triangular shape like we've seen in the Bankert repair and also see with meniscal repairs. Now, how do we penetrate the labrum? We try to keep the attachment of the labrum to the bone. We penetrate with the smallest possible instrument, which is the Accupass or the lasso. And we try to we do a very small penetration of the cartilage. We pass the guide wire, and then we do the labrum. Other devices like the suture retriever on the left, this is the nice, it's only one device that does everything. So you are holding the suture, you penetrate the cartilage, you throw the suture, and the same device is able to grasp the suture itself from back. So you go above the labrum, and then you hold it and you do your suturing. So this is an all-in-one device system. So do we preserve the contralabral junction or do labral detachment? So in the old days, people always recommended you do labral detachment. So you're able to do bring back the pincer back into place. However, the recent studies have found there is no need, there is no advantage to attach the labrum. Actually, when you leave it attached, it's easier to control. You can penetrate, it stays in place rather than being floppy in your operative field. And studies have shown there is less adhesions and revisions when you keep the contralabral junction attached. So the video on the bottom is actually one of my older videos again. I used to detach the labrum with a knife like most people did. We recede that and then we suture it back. And then we stopped doing that. We did not find any advantage of that. Now we come to the most medial anchor, and that you have to smoothen the bump at the front of the acetabulum. As we have mentioned, you do an extra distal anterolateral portal to try to reach that. And then you can see from the video, there's actually a curve to the medial edge of the acetabulum. So we want to reach the most medial part we can do the anchor. If you go more medial, the anchor will slip out. So it's important you reach that, you smoothen that surface out. We do all the instruments, the cleaning, the debridement from the top part. And then after that, we do the penetration. So once we do that, all anchors, while we're doing them, we need to be looking inside the joint to making sure we're not penetrating the acetabular cartilage. So as you can see from the picture, it's a more anterior and medial anchor target trajectory. And this is the look intra-articular. But also we go inside the hip joint to make sure we have the full thickness of the labrum and the full flap with our Accupass or suture passer. And you want to make the smallest possible injury and pass your wire So we've moved away. We used to use bird beaks in the older days. Now we've moved away to the smaller instruments. They cause less separation in the chondrolabral junction. And you can see now that we are in the most medial part of the delamination of the cartilage. So we know that this is the most medial part of our pathology. We're able to also move the suture in the right place. So we're able to get the suture in the correct place as medial as possible before the tensioning. We grasp the sutures. We do our technique of lasso while controlling the tension. Again, a very important technique to control the tension, bring that suture down while maintaining inversion of the labrum. So we're pulling one while we're pulling the other. If I pulled one too much, then eversion would happen. Now, lastly, is to the posterolateral impingement. When you have pincer at the bottom, posterolateral, which is more and more we're starting to find that. It's important that you get the labrum from the most posterior part. If you look at the video on the left, you'll find that there is actually an indentation on the femoral head from the pincer. So the femoral head is impinging on the back, on the pincer, and you can see this big indentation on the left side in the femoral head from the pincer. So we have to decompress the pincer all the way to the posterolateral area. And these people have labral degeneration, the posterolateral area, and they have an anterior labral tear and cartilage delamination, the anterior part. So you have a contre-coup pathology at the same time. You can see a very clear indentation of the femoral head in the posterolateral area. So we remove the pincer bone all the way down to 10 o'clock, as you see now, and then the labrum is usually degenerated rather than actually torn, but we still have to fix that and get it fixed so that it's back and stable after decompressing the pincer. So it's important to do peripheral first. We do acetabuloplasty without the traction to minimize the traction time. And the chondrolabral junction, again, as we mentioned, as in summary, we preserve that. We don't remove that anymore. We're using all suture anchors now. Usually drill 2 anchors right away in one step. That saves time on the instruments and saving operation time. So our average operation time now is 1.5 hours to operate 3 anchors in the hip, 4 anchors slightly longer, but this is with a normal sized cam. The 3rd anchor needs an extra medial portal. We loop around the labrum, which allows us to do the tension adjustment. And it's very important to maintain the labral seal and avoid eversion of the labrum. Thank you very much.
Thank you so much, Professor Hatem, for this very interesting presentation about a very interesting topic, femoroacetabular impingement. Thank you so much, sir.
Thank you, Professor.
I think we have a question to you, sir. Periportal versus interportal capsulotomy. What's your opinion, sir?
So for the capsulotomy, we're trying now to do selective capsulotomies. Some research has shown the disadvantage of doing large capsulotomies unless you're going to repair all of them. So we don't see the need to repair because we do selective capsulotomies, which you may call periportal, rather than large interportal capsulotomy. You need to have maneuverability of the instruments, but there is no target to do a huge continuous capsulotomy.
I think we have no more questions, sir. I want to thank you, Professor Hatem, for your participation. It's an honor for us, sir. We have one more question, sir. Oh, yeah, he's mentioning that it's a great talk, Professor Hatem. Thank you so much. Thank you so much, sir. Our next speaker will be Professor Ahmed Abdelazim. Professor Ahmed will speak about diagnosis, pathology, and treatment of CAM5. Please, sir.
السلام عليكم. متشكر جدا دكتور الأشهب للدعوة الكريمة وأسعد إن أنا أتكلم مع حضراتكم وورا دكتور حاتم على التوبيك اللي احنا بنحبها الهيب arthroscopy والfemoroacetabular impingement. So my talk will cover the introduction to the CAM femoroacetabular impingement, what's the pathology, the diagnosis, the arthroscopic technique, and the complications. The CAM, it's a bump at the anterosuperior part or head of the head and neck junction. And actually, it's not a new idea. This was written years and years before, in 1965 and 1975. It was mentioned in the literature by two radiologists, Murray and Stulberg, in which they defined that there is abnormality or a variation in the anatomical head that leads to secondary osteoarthritis. And it's not actually a primary osteoarthritis, it's a secondary due to a fundamental association with an abnormal proximal femoral morphology. Stulberg in 1975, he defined this abnormality as what he named pistol grip deformity, and identified this as a cause of osteoarthritis, which was query secondary osteoarthritis at that time, and it's proved now to be a secondary osteoarthritis and not a wear and tear. So what happens? This bump with hip flexion, it hits or abuts against the periphery of the acetabulum, leading to the pushing the labrum outwards and tearing of the labrum at its base. As you see in this video, the base of the labrum is torn, as well as shearing effect, creating a delamination of the hyaline cartilage from the subchondral bone, creating a peripheral cartilage flaps. So actually what happens is a peripheral lesion in which there is an extensive cartilage delamination or hyaline cartilage delamination together with a basal labral tear. So to identify it by clinical examination during the range of motion, if you have a big cam, you will find that the patient has an obligate external rotation with a flexion, exactly as a sign, the Dreeman sign, exactly like a patient having a sclipped capital femoral epiphysis. So actually the classical anterior impingement test, which was described by Reinhold Ganz in 1991, which is doing a flexion, adduction, internal rotation, actually pushing the femur or the bump against the injured labrum will cause pain or catching at this maneuver. And this maneuver is aggressive maneuver, which has a high sensitivity, but a low specificity. So you have to compare it with the other side to know the normal pain threshold of the patient, or the pain, what he feels in the patient, to control it and compare it to the other side. The more aggressive test is the Scour test, which is a combination of an external, derotational external rotation impingement test with a derotation internal impingement test, exactly like McMurray's test of the knee, stressing the injured labrum against the cam while moving from flexion, internal rotation, to abduction, external rotation with axial compression. And again, this has a high sensitivity and low specificity. So you have to compare it with distraction. Do it first with axial compression and compare it if the pain is relieved with traction. For radiographic examination or detection, you have to see the cam. The cam is a bump which is usually located at the anterior and the superior part of the head and neck junction. So actually between 3 and 11 o'clock. So that's the way that we have to look at X-rays to identify the anterior part of the cam as well as the superior part of the cam. So to identify the anterior part of the cam, you use the lateral view, either a cross taper or a frog lateral view. But to identify the superior part of the cam, you look at the anteroposterior view of the hip, as well as Dunn's view, which is done in a 45 degrees of flexion and a 45 degrees of abduction to get the most posterior or superior part, or the posterior part of the superior part of the cam. To identify the normal from the abnormal, you look at the alpha angle. Usually, the circumference of the radius of the head leaves the neck at a 45 degrees to 55 degrees. So you identify the center of the head and the center of the neck and draw an axial line, and then you measure the angle at which the circle or the radius increases. So that's the increase of the neck. And if you have a bump that will increase. So in this case, with a huge bump and the secondary osteoarthritis, the angle reached about 70 degrees, the alpha angle. Another radiographic signs which may indicate the presence of a CAM or femoroacetabular impingement is the vacuum sign. While doing a frog lateral view, you will find that the head is subluxing, and you have a vacuum between the head and the femoral head. Another thing is the impingement cyst. You find an impingement cyst, which is commonly misdiagnosed as osteoid osteoma. These are cysts at the head and neck junction due to impingement or due to cracks that happens during the impingement between the acetabular rim and the CAM lesion. To go to a more specific or sophisticated imaging is the MR arthrography using a special sequence, which is the radial oblique sequence, as well as using the very helpful 3D reconstruction to identify the extent of your CAM, how much you will go and remove this CAM from the anterior to the most superior part. Going to the treatment, you have to understand that the CAM deformity is essentially, you have to essentially excise all the CAM, and this has been associated with a better outcome. So in this review, an alpha angle more than 555 degrees after surgery was associated with the lower native hip joint survivability. And this data suggests that correcting the CAM deformity may positively affect the natural history of these patients. So we insist on proper CAM excision. This is your target during the surgery. Either to do it open or arthroscopically, you have to excise it completely from the anterior to the most superior part, preserving the vascularity, which is actually more posterior than the CAM lesion. So for me, I do it arthroscopically. I go, it's very important after going to the central compartment, I go for the central compartment first. After releasing the traction, my assistant moves towards the leg and he controls the leg. So he helps me to flex the hip, to internal and external rotate the hip so as to get a very good control. I go through the central compartment first, doing all the job, attacking the pincer, suturing the labrum, and then I move to the peripheral compartment. So a part of the proper CAM is to achieve a very good labral seal. So you have to do, as Professor Hatem mentioned, a very good labral repair with a proper labrum repositioning. So to avoid the labrum eversion and losing the labral seal. And then I go to do a capsulotomy and extend my capsulotomy if I need to a vertical limb. So to expose the CAM, you have to get a vertical limb so as to expose the whole CAM, except in the patients with micro instability or joint laxity, you can retract the capsule, and it's not preferable to do a capsulotomy so as to not to increase the instability that they have. So that's the arthroscopic view in which I did a capsulotomy between the anterior portal and the lateral portal, and then I extend my capsulotomy along the head and neck to expose the full CAM. And I have to see the full CAM to be able to excise it completely and not to leave any part of it at the end of my operation. So this is the CAM now exposed. The whole triangle from the anterior, inferior, and posterior are exposed. The boundaries. The most medial boundary is identified by doing flexion. Most of the CAM lesions starts to abut at 45 to 90 degrees. It's according to the shape or the how big is the CAM. So what we do is that we flex the hip to 45 degrees, identify the point of abutment, and then we excise what's out and we leave what's in, which is the weight bearing cartilage. So once we get identified and marked the head, as in the photo up, you identify it with radio frequency, and then you start excising with a burr what's outside this line, going from proximal to distal. So I use a 5 millimeter burr, and then I do a footprint going down full width with the 5 millimeter, not more. And this is my depth. And I start to move from medial to lateral cautiously without harming any more hyaline cartilage medially. And finally, I start to go away or distally, so as to prevent what we name a humpback deformity. So this is a humpback deformity. This is I did a cleft and I forgot about distal part, and this is what we name the humpback deformity, and you have to excise it completely. So what about medial and lateral? Medially, you have to go to identify the end of the cam medially, which is what we name, if you can see it inside the operation, this is a happy scenario. However, we usually identify it with an image intensifier. So it's the medial synovial fold. It's hard to identify it inside the operation. So it's preferably to be identified using an image intensifier. And laterally, you have to go to see the lateral retinaculum fold, which is the blood supply, which lies postero-superior. So you have to either retract the capsule and see the vessels. This is the soft spot or the lateral retinaculum fold, or where the blood supply enters. And this is an untouchable area. So you excise the cam till this area. You should not touch this area, because it's the blood supply and it will cause an AVN if you touch it. And it's very easily seen by an arthroscope. So again, this is another case where you will find that they retract the capsule laterally and see the vessels inside with inside the lateral retinaculum fold, which is the terminal branches of the medial circumflex. So you go with the burr, you get out the cartilage, you scratch it either by a curette, and then you remove it. You remove the cam with a 5 millimeter burr, creating a footprint and going from proximal to distal, from medial to lateral. And once you finish, you to make sure that you excise the proper diameter and the proper boundaries of the cam, and you excise it completely, you have to do a dynamic test. So while rotating the hip, flexing and extending the hip, to make sure that there is no cam left, medially, laterally, distally. So dynamic and intraoperative dynamic examination is very important. So that's the end result that we want to reach: a proper labral repair with a proper labral seal and a good cam resection with a clear dynamic examination. So again, this is what we want to see. And this is what we want to see in the post-operative x-rays: proper labral repair with the proper placement of the anchors and a good cam resection with a proper offset, head and neck offset. So what's the complication? The most commonly encountered complication is under resection, and it has been reported that the patient will have a lower outcome if you under resect the cam. Over resection is another problem, and it could lead to a fracture. However, this is not commonly encountered, and there is an inquiry now about doing too much resection until reaching an instability. An instability comes from over resection or over capsulotomy and over resection of the head. Nowadays, we are speaking about a new concept, which is making a slope rather than a right angle. As if you create a right angle, you're actually doing a micro instability. And this was achieved in 30% of the patients who did CAM in this study. During deep hip flexion, because during hip flexion, while doing a right angle resection, you actually are separating the labrum and you are losing the proper labral shear in deep flexion and creating a micro instability. So now it's preferable to do it as a slope rather than a right angle excision. Other complications, which is more theoretical, like iatrogenic injuring the weight-bearing cartilage, getting too much adhesions due to lack of proper post-operative protocol, injuring the lateral retinaculum vessels and getting an AVN, instability due to extensive capsulotomy, especially in patients with ligamentous laxity, and you have to take care of this, or recurrence from bone remodeling, which is not reported. So our take-home message is that CAM deformity is an aggressive femoroacetabular impingement on the hyaline cartilage. CAM deformity, or to diagnose a femoroacetabular impingement with a CAM, you have to have a very good positive clinical signs as well as findings in the radiology, the two together, concomitant labral surgery, labral tears in which the femoroacetabular impingement was not addressed has a poorer results. Osteoplasty without labral management also has a poorer results. So you have to do both. CAM resections requires meticulous techniques to prevent under or over resection. And lastly, I would invite you to join us who is interested in hip arthroscopy and young adult hip pathologies next week in our Cairo University course. And Dr. Hatem is one of the eminent faculty who will join us. And you are يعني تنورونا كلكم اللي interested في الموضوع ده هو. شكرا.
Thank you so much, Professor Ahmed, for this very interesting talk. We have two questions for you and, of course, to Professor Hatem. How to calculate the alpha angle again, please, from Dr. Muhammad Riyad.
طيب هو احنا الالفا انجل هو الفكره كلها ان احنا بناخد السنتر، بنرسم مورس سيركل ونجيب السنتر بتاع الهيد، وبعدين نجيب السنتر بتاع النك ونوصلهم ببعض، و this is the head and neck axis. And then we see the radius of the circle. The radius of the circle. الراديوس بتاع السيركل ده مثلا السيركل بتاع الهيد مثلا الدايمتر بتاعها هنعتبره ان هو 50، يبقى الراديوس 25 ملي. نبدأ نلف من الاكسس بتاع الهيد اند نيك جانكشن ونشوف الراديوس دون هيبقى ريتشد امتى. لو هيبقى ريتشد عند اول السيركل، اول ما الهيد بتسيب النك عند 45 ل 55 degrees this is normal. لكن لو الهيد اند نيك جانكشن او النك ليها اكستنشن زياده هتسيبها عند 60 او 70 درجه. This is the CAM.
Another question from Dr. Gamal Qasim. How can we identify vascularity accurately while CAM removal?
هو الفكره كلها ان احنا بنشوف one of the very important steps in doing CAM، ودي حاجه دكتور حاتم يعني انا حضرت معاك لازم يعملها في كل الحالات وكلنا بنعملها في كل الحالات، هي ان احنا لازم نشوف اللاترال retinaculum vessels. It's very easy to see it. You just go and retract the capsule عند الساعة 12 أو the most lateral, and then you go with your 70 degrees scope. هنشوف اللاترال retinaculum vessels، هنشوف السوفت سبوت، ودي الحتة اللي انت بتبقى ما بتقرب لهاش. انت ممكن تشيل الكام proximal ليها وانتيريور ليها، لكن في الاخر خالص انت المفروض ما بتقربش للحته اللي هي باسترو سوبيريور دهيا، علشان هي دي الحته اللي بتدخل الفاسلز.
Another question, sir, from Dr. Muhammad Osman. Does pincer impingement damages the acetabular labral complex, while in CAM type that damages the chondral surface of the acetabulum?
So actually most patients will have both pathologies. يعني sometimes females don't have much of a CAM, but the majority have a combination between CAM and pincer that the combination leads to the actual impingement. Of course, when you have a larger CAM, it damages the articular surface more. If you have pincer, it damages the labral more, but you find different combinations. So we deal with all pathologies as you go in. It does not really, I don't stress much because, as I said, most of the time I'm dealing with both pathologies rather than a single pathology.
Thank you, sir. The last question, sir, from Dr. Sayed Yassin. What's the main indication to do CAM resection in patient with PHY?
معلش ايه الانديكيشنز؟
The main indication.
بيسأل المين انديكيشن هو ان العيان يكون ما عندوش osteoarthritis، او ممكن نقول تونس جريد 1، لكن لو عنده osteoarthritis فخلاص هو مهما لو شلت له الكام I don't think that you will stop the pathology. لو دخل في اوستيو ارثرايتس فعنيف. فهي احنا الفكره كلها ان الانديكيشن بتاع ان انت تعالج فيمورو اسيتابيلي امبنجمنت ان جنرال هو ان هو يكون مفيش اوستيو ارثرايتس. الاوبيسيتي اتس ريلاتيف انديكيشن بالنسبه للهيب ارثروسكوبي. بالنسبه لي الايج اللي هو لغايه 50 55 اتس ان انديكيشن ان احنا نعمل. above this it will be يعني حالات معينه selective cases below the age of 50 ل 55 I do it بعمل كل العيانين in case ان هم ما عندهمش تونس اكتر من تونس 1 osteoarthritis.
Finally, thank you so much, my dear professors, Professor Hatem Jalal Saeed and Professor Ahmed Abdelazim, for sharing your experience with us in this very fruitful session. Thank you so much.
Thank you, sir.
متشكرين. تسلم.
شكرا to محمد بيه.
شكرا يا أستاذ. Now we have to move to the hip oncology session, and the first speaker will be my dear professor, Professor Walid Abeid. Professor Walid is the head of orthopedic department, Cairo University, and the eminent star of hip oncology in Egypt, the Middle East, and all over the world. Professor Walid will speak about hip transposition as a reconstructive method following pelvic resection. Professor Walid, please. Professor Walid, you are with us, sir?
Is my voice clear?
Yes, sir. It's clear
Dr.
now.
Muhammad.
Yes, sir. It's clear,
Yes,
sir.
is my voice clear?
Yes,
or there
but
is
I
a
think
problem with the connection? It's clear.
you are
Okay.
muted, sir.
Shall I share the screen?
Yes, please, sir.
Is the voice clear?
Yes, sir. But you didn't share your presentation, sir. Professor
Okay.
Walid, you hear me, sir?
Yes, I can hear you clearly.
Yes. Can you please share your presentation, sir, please?
Is this okay?
No, it's not obvious, sir.
Yes, I shared it.
No, it's not obvious, sir. It's not shown.
Okay.
Yes, yeah.
Okay.
We can see it, sir. Yes, sir. Full screen, please, sir.
Is this clear? Okay.
Yes, sir. Full screen, please, sir.
Yes, this is okay.
هو حضرتك الصوت بيقطع بس يا دكتور وليد بيساعدك. بروفيسور وليد.
ايوه الصوت كده كويس يا دكتور محمد.
الصوت بيقطع شويه يا فندم. بيقطع شويه سعادتك.
الصوت مظبوط؟
كده احسن يا فندم. Full screen, please, sir. لا, we lost the connection, sir. بروفيسور وليد.
دكتور محمد انا مش عارف الصوره.
لا الصوره lost يا فندم.
كده طالعه ولا؟
صوره سعادتك كده طالعه. Would you please share your screen, sir? Yes, we can see it, sir. Yes, please.
Is this
sir.
okay?
Yes, sir. Thank you so much, sir.
Okay. I'm going to talk about hip transposition as a reconstructive method following tumor resections of the pelvis. So there are several types of resections. It could be either including the ilium or the periacetabular area or the pubis. This is type 1, type 2, and type 3. If we include the sacrum, it's type 4. And we can have combinations like P1-2 or 2-3 or P1-2-3. These are different resection types. Following resection, we have different methods of reconstruction. This could be biological reconstruction, endoprosthetic combinations of both, or even fusion of the remaining bones, and sometimes we don't do any reconstructive option. You can see here that there are used endoprothesis, ice cream cone prothesis, saddle prothesis. Sometimes we do resection and recycling of the resected area, and then reconstruction with a combination of recycled and total hip replacement. Sometimes we fuse what's remaining of the bones, like here, ischiofemoral fusion or pubofemoral fusion, iliofemoral fusions. Sometimes we leave the pelvis open following resection of type 1 resections. So whenever we have an acetabular affection, we ask ourselves, are there any acetabular part that is resected? If yes, then we see if it's a partial or total resections. If no acetabulum is resected, then we can leave the pelvis open. So when do we do hip transposition? We do hip transposition whenever we have type 1 or 2 or 2 and 3 are resected. These are when we leave the pelvis open, like this.
هو حضرتك البرزنتيشن باظ هنا. Please, Dr. Ibrahim, please stop your Dr. Ibrahim Abu Amira, please stop your screen, sir. Dr. Ibrahim Abu Amira? Yes, sir. Yes.
Is this okay? I'll do it again. Something has been lost.
Yes, sir. I'm so sorry, sir.
Sorry.
عملوا ستوب على كده.
بعد اذن حضرتك يا فندم، لان احنا مش عارفين نشيع.
طيب تمام.
اتفضل يا دكتور وليد بيه. اتفضل يا فندم.
لان في حاجه عندي مش مظبوطه. هو
لا كده
انا كده طالع مظبوط عندي.
تمام يا فندم.
كده شيرد.
يس سر. يس سر.
تمام. Okay. So we can do recycling and combinations, or we can do fusion of the remaining bones. When we have a periacetabular resection like this, we can do periacetabular resection followed by iliofemoral fusion. And these give good results.